Hello, my name is Jan Kalika, and I'm going to talk a little bit about innovations and technology for successful outcomes in modern orthodontics. Would love to get some of your questions and feedback. And my company's name is Image Orthodontics, and we have offices in Northern California. So I'm going to give you a little bit of preview about myself. I'm an international master in chess. Actually played in junior for US, and I think we won the national in 1991. And so a lot of my approach to orthodontics is through the thinking of chess. It's kind of the orthodontic reminds me when you start a game and you think about the moves ahead and you go from beginning to the end. I really use the principles of chess in my orthodontic practices. In terms of my education, I came from Moldova in 1989 without speaking any English. I was an immigrant and had to make it through and attended UC Berkeley, graduated in 93 in chemistry, worked for a year at Genentech, which is a biotech company here in the Bay Area, and then went to Harvard School of Dental Medicine, graduating in 1998 with a dental degree, and finished my orthodontic residency at UCSF. I've been practicing over 20 years and lectured on a lot of major orthodontic conferences. I am a key opinion leader for Straumann and some of the other companies like Carestream. I've done a lot of lectures in both national and internationally. And I'm giving a lot of my time to the organized dentistry. I'm on the UCSF Dean's Council, so I'm helping the dean with some of the strategic initiative for the dental school, and I was on the board of University of Pacific Dental School. I'm advisor for many different companies, like in tech companies in the Bay Area, and I'm a partner of Revere Partners, which is the only, as far as I know, oral health VC fund. So I like technology, and I founded one of the technology companies called DiagnaCat. I'm one of the co-founders. Part of the success story in our mission in our offices, we promise to use the latest innovations to provide highest quality care for our patients. So we go over our mission statement a lot and we change it every year, but this line never changes. The innovations is really part of our DNA, and we really manage with that in mind. And I feel in the newly orthodontic office, to stay competitive, you have to use some of the innovation. We have a very close team. A lot of people work with us for 18, 20 years. We own a chapter of Smile for a Lifetime to give some of the care for underprivileged kids. So a lot of those things you have to do. What happens with CBCT scanning technology is that, over the last years that I was practicing in, there's been plenty of CBCT innovations and machines that are coming on the market. Of course, Carestream is the ones that we use because I'm a key opinion leader, but there's been other things like iCat, Kodak, which is Carestream, Plan Mecca, Promax, Serona, and many others. The new innovations are the model scanning. So we use a lot of digital models, and there's plenty of those intraoral scanners, including iTero and Trios now that are kind of newest ones. I used to have the first kind of Sure Smile scanner. The appliance design, we use Invisalign Sure Smile, for some of the wire bending. And, I could talk to you a little bit about the aligner kind of, we also use the Straumann company now. So we're really aligned with their culture. So for aligner design and appliance design, we use the Straumann, which is ClearCorrect. And we use artificial intelligence. So some of the AI companies that are on the market now are Overjet, Grin, DiagnaCat, which is one of the companies I was the co-founder, Pearl, Promaton, Dental Monitoring. There's a lot of AI that's coming on the market. And I feel like 10 years from now, most of the doctors are going to use AI principles. And I've been using it very successful in my practice. So I feel DiagnaCat, we're the only ones that kind of crack the 3D AI circle. And Promaton, which is actually Straumann owns, they're actually trying to do stuff. So every case that I do when I take CT scan, I do segmentation. I'll show you some of the cases. So when the patient comes in, I use the AI, I take CT scan, intraoral scans, and I take photos. And the AI shows me each individual tooth and what's happening with it. And for example, this is an illustration of tooth number 15. And in red, it shows me what the problems are. It says there's a widening PDL at the root level and there's periodontal bone loss. It will tell me if there's any periapical lucency. So it uses 16 different neural networks with DiagnaCat to be able to analyze each tooth in 3 dimensions. And, so CBCT has really brought a lot of innovations to the way I practice. And the way we practice is we use airway-centric orthodontics. So we did a lot. I've been always airway friendly, tried to do non-extraction. I was one of the first Damon users, tried to move teeth slowly and do expansion. But when you look at the traditional cephalometric analysis and you look at the ceph tracing, you kind of see that even the quality, is much, much better when you start using CBCT. One of the innovations with CBCT is also the fact that you can analyze teeth in 3 dimensions. So when we do segmentation, we'll have a lot of segmented teeth where we could see the roots and the bone level. So this is an illustration of the traditional ceph, and I'm gonna show you how it changes. Look at the CBCT ceph. So this is extracted from CBCT. You could see the quality, you could see the sinuses here, and this is a 2-dimensional. You still cannot see airways that well, but when you start going to 3D, you start seeing the TMJ, you start seeing some of the symmetry things, and it really creates a much better quality for your diagnosis. Now, when you communicate with your dentist, they obviously can appreciate the fact that you're state-of-the-art technology, but you also share some of the images that helps them in treatment planning of the cases that are restorative in nature. So this is, for example, a ceph analysis that's done by AI, by DiagnaCat. It does automatic ceph tracing for me. Obviously, I don't have time to sit and do ceph tracing of every single patient. So automatically, I kind of know where the teeth are in relation to soft tissue in the face. And I could see some of the symmetry, if there's midline deviation, if there's a chin deviation, is it a skeletal problem or a dental problem? But the biggest thing is that I feel like that a lot of orthodontists in my competitive area miss is the envelope of where your bone is. How far can you expand? What's your kind of proper envelope of expansion? And that's, as you know, when we do orthodontics, we're going to look at the transverse dimension as the first one. This gives you a really good view of like, okay, I don't have a lot of buccal bone or things like that I can move teeth into. So maybe I need to do surgical expansion or use the MARPI, which is maxillary assisted rapid palatal expansion. So I look at the bone and I kind of decide how much bone I have lingually, how much bone I have buccally, and that's part of my orthodontic report that's done automatically by AI, right? So this technology helps me to figure out like where the bone is, how much can I move teeth, buccal, lingually, expansion, because a lot of those people who just do clear aligners, for example, I use a lot of Clear Correct or Stroman brand for simple cases. So you need to understand where you could move teeth to. And we talked about palatal suture. It was a very old concept that the suture closes, while in the latest, I guess the last 10 years that I've been practicing, I've been using on adults maxillary surgically assisted expansion, meaning I put the mini screws on each side of the suture and I'm able to expand adults. Obviously, there's some limitations and you need to know the ages and you need to figure out what's a good case selection, but we know that the suture doesn't close into adult ages and you could still crack it open and improve not just the airways in 3 dimensions, but if you don't have buccal bone and you're in crossbite, you can actually expand that jaw and you could get, here's some of the images where you could get 3-dimensional expansion all the way to the bridge of the nose. And it actually helps you with the canines, but it also, you could design your expansion where you want to expand more anteriorly or posteriorly. And you could get decent amount of expansion, but if you expand improperly with just the use and you don't know where your bony limitation, you can push teeth out of the bone. And I think as orthodontists, we're guilty of pushing teeth out of the bone all too often because we didn't do the proper diagnosis and didn't use the technology to kind of measure this. Now, skeletal asymmetry, such as condylar hyperplasia, when I do my analysis, I automatically get those images and I could look at it and I could figure out, okay, here's the condylar hyperplasia case. well, one of the condyles here on the left side is hypoplastic, and now it's a skeletal problem. Well, I had a general dentist trying to do Invisalign case, trying to fix the teeth, but it doesn't work. And you could see how when I analyze it, I could see that, there's a condyle problem. Same thing, another Invisalign case that I had to rescue with condylar hyperplasia with an open bite. It seemed like an easy aligner case, but that's a skeletal problem that we needed to fix. So in the condylar hyperplasia, I also get, when I start the case, I get this view and I could rotate the jaw and really understand where the gist of the problem is and figure out what my diagnosis is. So technology is very important. And then I could look at the teeth and it looks like what could be a simple aligner case that becomes a skeletal asymmetry case that you really need to treatment plan properly. And you could see how, in this case, like I could, there's superimpositions of the before and after. We could color the teeth. I could figure out, okay, and show the patient, like, here's the asymmetry. This is what we're looking at. And, the patient needs to be aware, what are we fixing? Are we trying to line up the teeth and not fixing the skeletal problem, or is there skeletal fix? Same thing as the TMJ. I automatically get TMJ analysis and I kind of look at it and decide where's the condyle. You can even do the soft tissue thing. So I'm going to take you through some of the cases. I work with Dr. Plaxen, who is a really good friend, an orthodontist, and created some of these images. But you could see when I analyzed the images using the AgnaCAD, I could rotate, I could see the airways, I could look at the facial structure, I could see how the teeth are fitting, and I could also see, for example, in this picture, we could see there's a septal deviation. And remember, I treatment plan using airways, then I look at the face, then I look at the teeth, right? So when you start thinking about airways first, you need to understand, is there a nose breathing patient? Is there expansion that we need to do? What kind of expansion? Does it need to be skeletal or dental? So those are the kind of things that technology allows you to do. And then you evaluate the teeth and the roots and trying to come up with a plan. How do I want to line up the case? You can actually do a lineup on the computer, and you can do the setup. There's a lot of digital design companies that do that. You could decide it's a skeletal problem or a dental problem. And, sometimes I work with ENTs and speech pathologists and, try to get patients to do some exercises to decide, what do I do with this patient? How do I gain stability? A lot of times my TMJ patients, which would do quite a bit of the TMJ problems, they have airway problems, and you take care of the airway and decrease the inflammation, and the TMJ inflammation goes away. There's a pathway of how inflammatory processes like airway issues or even food allergies connect to overall condition of the TMJ and the allergy. I look at the asymmetry and I decide, okay, here's the upper jaw. It's in the crossbite unilaterally. Is it skeletal dental? How are we dealing with airways? And then I look at the teeth and try to figure out, what do I do with this? And this is an example of a patient that was expanded with MARPE and the mini screws. And you could see how in the adult case, we can open up the suture and then successfully treat it. I treat a lot of those cases with aligners. Again, I use the Invisalign and I use the ClearCorrect, and I like the ClearCorrect, some of the material and, the fact that the Straumann has a very strong culture. And sometimes, we find many things like impactions. CBCT allows us to visualize like where the teeth are, how far they're related to the nerve. And you look at the traditional panel and this is a case, I think it was sent to me by a dentist saying, hey, I need to open up a space for an implant. And on the panel, you don't see a tooth. But when you do CBCT scan, you could see the tooth is actually pointing upwards. And you could see, okay, now I could potentially bring the tooth into the arch and I don't need to do an implant. And, some of the dentists started the treatment by opening that space and doing an implant, but, didn't really notice that tooth sitting there. So very, very important. So when I do the cases, I actually sometimes for educational purpose, and we have an interesting model in our office. We have a lot of orthodontic partners. So we actually treatment plan together. So we usually have 2-3 orthodontists looking at each individual case and deciding what is the treatment plan. So which is a great, I think that this is also a model of the future, is to have partners in orthodontics where you could run some ideas and technology and work together. This is 3D illustration. We can actually do appliance design in 3D and decide, like in this case, we're distalizing with mini screws and bring the canines in. And difficult canine cases, that ordinarily would have a lot of root resorption or issues, you can create like systems of vectors and mini screws and be able to create this design, like in this case, to be able to bring the teeth in the right position. And you could see, also, again, look at the airways and, look at the face and the teeth and how do I bring it in? Where do I put the, mini screws? And we can do superimposition to see what actually happened. You could see the canine in the red, and now in the blue, you could see how the canine is moving, and you could figure out exactly where you need to be. And again, you could design the cases with phontics and whatever you want to do, but the technology and how I practiced 20 years ago is totally different than what I'm practicing today. And I think that if you're not practicing, I think you're going to be behind. So it's very important to really get on board with this stuff. And like I said, I do a lot of pretty much every case. I do segmentation of the airways. I try to do 3D digital design. And we're getting, as orthodontists, more and more difficult cases. So it's important to kind of show that you could actually be a good orthodontist and you can plan the case. Here's the appliance design where I'm putting screw all the way almost to the beginning of the sinus. So you have to measure your maxillary expansion device and how long your mini screws are going to be so you could design the appliance. And then you could put things in. And the other thing that's very important is that I can visualize things, like I could do superimposition and decide, like, this is where extracting teeth, we're not doing extractions. We can get distalization instead of taking teeth out, create very favorable profile. And how do we understand this? This is an image of Dr. Plaxton again. And then, so he's, I think, amazing in images, but superimpositions, you see his thing, and I could look at the case before and after, and I could see this is what happened in the case. I distalized 3 millimeters. You could see the root moved. I kept the teeth. If you want to put the bone in, you could see distalization. So you start understanding by using technology your mechanics. What have I done right? What can I tweak and what can I adjust? So superimposition cases are very important. And this is a case that's very interesting. It's a class 3 case using mandibular plates, which is, again, kind of a new thing. We haven't used it maybe 15, 20 years ago. And this is a class 3 kind of adult patient, late teenager, that we think the suture is closed, where we can use the mini screw and plates and treat severe class 3. And you could see how I'm mesializing the whole maxillary segment forward, again, being very bone friendly, considering that I'm not going to push teeth out of the bone. So you could see this is beginning and the end, and how we were able to do a full class 3 case into class 1, without doing orthodontic surgery, but using the mini screws, the CBCT technology, the model design. And you could look at the airways and you could see that, how much for this particular case, like look at the beginning and the airway, and look at what the picture in the middle shows, how much airway improvement we're getting for those cases. And again, we're airway-friendly orthodontists. We've always been that way. And I think that there's more and more studies coming out how important it is and how much the mouth and the tongue space and the positioning, affects the breathing. And of course, doing superimpositions in 3D and create like some of the skeletal-based stable points allows you to understand what exactly is being done in this case. And I could look at the bone level, because I'm segmenting the teeth, and look at the airway in anterior posterior position. Look at the initial and the end. Look, we don't even understand. This is an amazing service we're providing to our patients. That's why I like practicing now much more than even when I started. And you could see some of the development. You could see the roots, decide on what to do with wisdom teeth and the proper timing, and really understand what is your mechanics doing for you so you could become a better orthodontist. So this, again, technology and the new aligner design is also amazing. Like the fact that we have 3D controls, I use it on both Invisalign and Straumann, the ClearCorrect cases. I start doing most of my simple cases with them because I like the material. Again, I like Straumann and the innovations. Like I went to visit the company and they had this machine that measures the force on each tooth in 3 dimensions, and when the plastic applies the force, how does it move and how much grams it applies to. And again, you could see, how do you change a occlusal plane by using certain mechanics. And, I would say I use a lot of aligner cases, not much more than braces, because I'm able to superimpose and get to the point where I feel like I can get the same results using, for example, clear correct aligners that I could do with braces, especially with those MARPI patients or maxillary rapid palatal expansion cases where I need to close the space. This is a difficult case, again, severe class 3 full cusp bilateral crossbite with the plates. You could see how much change you could do. And this was not possible when I came out of residency, like those kind of cases. And then you understand they're able to preserve the occlusal plane. You do the superimposition. We brought the whole maxillary teeth forward and analyze it. What happens to the teeth? What happens to airway? Did I push teeth out of the bone? Am I maintaining this thing? Obviously, those are difficult cases that would have been only surgery 10 years ago, but you could see how much we brought teeth forward on the picture on the right. You could see where the left side of the teeth shows you. And if you look at the picture on the left, see how much airway changes. It's a little movie, I'll play it again. How much airway changes are happening when we correct that class 3. And you could see the mini screw design all the way to the sinus. So this technology, the superimposition, the CBCT scan, allows you to become a better orthodontist and really drive clinical outcomes in your patients. And you could see before and after. You look at the occlusal plane, we're able to maintain it. We didn't open it up. We brought the maxillary teeth forward. We're able to keep the bone. So this is amazing. You could also see, where your bone, like on a class 2 correction, you could see where the jaw is growing. We're trying to figure out before, does the Herbst appliances work? Function class 2 mandibular advancement. And you could see exactly, is it a condylar growth, like in this example, or is it a growth of the mandible, where you could see the body of the mandible growth. So you could see superimposition in your cases and figure out, this is what I used and this is what I got. And then intelligently tell patients, listen, here's my beginning and my case at the end, and this is what happened, with some of the changes and how I was able to achieve the before and after. Obviously, we talked a little bit about supernumerary teeth. I don't want to go into a detailed example, but with technology, you could see a lot of things. CBCT for orthodontic surgery. So I use the robotic orthodontics and try to get the wires. And now I'm going to start working, with, again, some of the aligner companies I could do surgery with the same quality outcome. And I kind of tested out, and you could see that you could do surgical planning. You could do the appliance design and finish those cases in much shorter, shorter time frame, but also get a very good quality result. Here's a 6 months case on the class 3 mandibular, but it's orthodontic surgery. So I was able to do the setup, and you could get the really good result in a very short period of time. And again, that's with the newest elevation. And then TMJ, I do a lot of TMJ treatment and try to figure out where the problem is. Sometimes I do cranial nerve exams. Sometimes I look at the, airways and figure out the problem is there. Sometimes it's food out. I mean, how do you eliminate inflammation? And, the fact that, when you close the mandible, and the mandible is like a pendulum and you don't have overjet, maybe you're pivoting your lower jaw back. So you can understand where's your disc. We're starting to segment the soft tissue where the nerve and the discs are visible in 3D. And sometimes, again, some of the degenerative changes that I see, I had a very interesting case where I couldn't see on the X-ray a subcondylar cyst, and the jaw kept moving to one side. And when they got the cyst removed, when I saw on CBCT, the jaw lined up everywhere. But the second opinion orthodontist was planning that case for orthodontic surgery. Now, if you didn't see the cyst and you were going to do orthodontic surgery, the cyst was going to grow. It would have been a disaster case, right? And you could really understand and analyze TMJ. And especially, this is the case I got with a condylar resorption that the dentist was doing Invisalign on, and it wasn't very stable. And you could actually look at the TMJ segmented. So anyway, a lot of, again, the technology is just helping us with an understanding of the airways, understanding of the joints, so we could create those stable patients. And I calculate the total volume of airway and the minimal area. And then, this classic study on airways that actually one of my teachers, when I went to UCSF, Dr. Varkovic, was my teacher in craniofacial. They did this experiment on primates to prove that airway changes your occlusion, it changes the stability. If they use the primates to kind of close their nose and close their mouth and see how the jaws are developing. And a lot of them had cross bites and multiple other issues. They've also done a lot of, this guy Christian Guilleminot, who did a lot of study out of Stanford, to show that we have an epidemic of small jaws and what happens with nasomaxillary complex. Some of the sudden infant death syndrome had hypopnea episode. And so we know airway is important. And outside, I'm not going to go to obstructive sleep apnea because it's a whole separate lecture. But the idea, I look at it and I analyze it and figure out where the problems are to be able to then use the technology and decide what does this patient need, and I follow still the kind of medical scientific approach. The standard of care for airways is taking adenoids out, doing turbinectomy, doing CPAP machine. Sometimes we do mandibular advancement appliance. But sometimes I do the rapid maxillary expansion and the airway problem goes away and it's a permanent fix for adults. Sometimes we do Herbst appliance on late teenagers. So there's a lot of different variations of how you can treat the patient. And without all this information and having a multidisciplinary team, you're not able to really understand where to take it. So that's why the topic of my thing, we want to take a patient and kind of see where the jaw develops. And this is one of my cases where I use the maxillary rapid palatal expansion. And you could see in a month, we're getting a lot of expansion. This was a TMJ patient with severe pain, airway issues. And we expanded her. You could see on the picture on the top, there's a crossbite bilaterally. In about 1 month of Marpi, we expanded it out and opened up the suture. And then, again, I would use aligners for this kind of case now. This is a case with supernumerary and sleep apnea that actually had a phase 1 that wasn't successful. And you could see airways, like there is no airway. So obviously, we expanded this patient, put him in appliance, and you could see the airway volume is much, much bigger. But what I use is 3D airway images, and I need to kind of look at it visually. It gives me a clue if I need to dig deeper, and I use the extensive questionnaires and understand from patients where they are. And then I figure out what's the path of treatment, because how do you know what the treatment is if you don't know all the problems and if you don't know your limitations? So I feel like the fact that we could have this technology and use it in our offices, allows us to be better orthodontists and more, listen, we don't know what we don't know. And I didn't have segmentation of airways before. And when I was kind of working on this software with the team, we wanted to really understand how do we segment the teeth, how do we segment airways, the jaws, the joint, and create virtual articulators. So I always, like SureSmile, when it came out, I was excited and I used the digital treatment setup. I had the first scanner that I could get a hold of myself and I could see, okay, now we could see the bone underneath the gums, which is great. But it also was great for collaboration. I could, with my restorative dentist, I was able to, do those multi-special. I belong to Spear Study Club, but I've done a lot of different, like Seattle Study Club. I really like multidisciplinary cases where I could prepare the teeth for veneers, but I want to make sure the cases are stable. I want to make sure I fix the tongue position. There's no tongue thrust. So I do some myofunctional therapy exercises. So you need to become an orthodontist, a kind of multidisciplinary approach and understand the big picture, almost like I said, the chess. You need to understand the strategy of the whole game and not just concentrate on the pieces of the teeth being straight, but also think about how's the child going to grow? Or what is this adult going to look like 30 years from now? What is the sleep apnea consideration? Some orthodontists are still using headgears and extracting teeth. I mean, that's probably, because they're really not looking at the whole picture, in my view. I mean, listen, sometimes you need to take teeth out, right? I mean, there's every case, but there are cases where you could get out of extractions, as you saw in class 3 cases, by expansion, by using some of the virtual articulation. But using digital treatment planning, using mini screws, you can do a lot of things. And you could actually take initial photos and do the digital plan and really get very good result, in your planning, and whether you use aligners or not, and figure out, okay, if my roots are out of the bone from the get-go and I treatment plan and I put it in the bone, am I going to actually get this result? And some of those images, the orthodontists created, I have a case now actually from one of the faculties at the local orthodontic school that the periodontist sent to me and said, like, I can't work with this orthodontist. It was supposed to be orthodontic surgery case. And basically he just decided to open up 2 spaces for implants on the lower and just blew teeth out of the bone. And this is the segmentation, for example, that I use on every case to not to have this kind of problem, where I could see, hey, at the front, I don't have the bone. How are you going to pull those teeth forward? And the case turned out to be a disaster, because now I have to bring the teeth back, or I have to get bone grafts, do a surgical planning to kind of get the case back where it came from. So the fact that I have the tools and the new technology, and like I said, I was the early Damon adapter. And the reason I adapted Damon, because I didn't want to see those faces, right, that they talked about. And I'm using different self-ligating brackets now. I'm not a Damon user anymore, but you could see, the extraction cases, non-extraction, and the fact that you can actually slowly move the teeth and expand out of it with a very comfortable level, with low friction, with good patient comfort. And you could see, for example, this is one of the cases that Damon treated. You look at the face, you don't want to do extractions on this kid. So how do you get out of it? You do slow expansion, right? And you kind of observe this case, and you could see slow posterior expansion in this region, and you could get out of it without taking teeth out, getting really good arch form, getting enough space for the tongue, healthy gums. And we use some of the wires that have, like we use a Bioforce wire out of Japan that applies more pressure on the molars, a little bit less on premolars and less on incisors. So there is a technology to get out of this kind of crowded cases without extractions in a short period of time. So the before and after, you could see. Now, sometimes the big thing for me is almost like, again, as a chess game, you want to finish it in a shorter amount of moves. So I'm very big on efficiency. I don't want patients to come unnecessary multiple times. I hate the cases where I see transfer cases that come to me, 6 years later, and the orthodontist is doing it. There shouldn't be a lot of 6-year cases, like some difficult cases, cuspid impaction. Even those you could plan to be very efficient. And you could use, like I said, robotic orthodontics. You could use digital imaging, computer modeling, high-tech materials to be able to get to those results. So I think whether you're a general dentist doing ortho or working with orthodontists, you want to work with somebody who could take a scan, do the kind of the setup on the computer, collaborate with the multi-specialty team, with the dentist and the periodontist, do a setup, right? See the superimpositions, like, okay, here's where my teeth are going to be. Do the digital design, like this is an open bite case. Here's the design, how we're going to close it. And this is the real case where you take an open bite and in 9 months you get it. Efficient result, very quick. And for example, this is a 34-year-old patient. I'm going to show you a case in 09, and we did this digital planning. She had a TMJ problem, interferences, and we had a wedding. We needed to finish her. You could see the root shortening, right? So the question is, I haven't seen root resorption in my practice for a long time, because our treatment cases are very efficient. We'll watch it. We'll put very minimal forces. I mounted the models. I saw the interferences. Basically did the digital setup, right? So this is before. You could see from intraoral scan, you could see occlusion is not good. It's only touching few teeth. I did the plan, digital plan, and bend the wire. You could see I'm building an occlusion where you have equal forces on a lot of teeth that are even, and create a little bit of overjet because of the TMJ patients. You want that envelope on function to work. And so we created this plan, use robotic wires. And we used a couple of wires, and in 8 months, we're able to finish this case perfectly with no interferences, no more root resorption. 5 months in short, small wires, 7 months total, 5 visits. And this is another case that before you could see class 2 crowding, you could finish it in 6 months. So there, as long as you use technology, proper forces, multidisciplinary treatment, you can really be efficient in your treatment and be successful and have a lot of successful patients and appreciate. And you can show them as a patient education, here's the pressures on the teeth, here's the surgery we're going to do, this is how we're going to plan your case, and this is where we're going to put the mini screws. And then you could say, here's the before and after, we're going to build up the lateral incisor, and we're going to push your teeth into the bone, and we're not going to have this recession, and get a really successful outcome. One more thing, I'm going to talk about early orthodontics. I'm a big believer on treating a lot of kids early, because you want to have a normal jaw development, almost anthropologically and embryologically, like your upper jaw goes down and forward, and your lower jaw goes down and forward. In an open bite case, your lower jaw becomes vertical, as you all know, and the upper jaw, instead of like moving down and forward, it starts getting a little bit of retarded growth if you don't have the proper airway and tongue movement. So a lot of those cases I treat early. I work on the habits. I work with my functional therapist. I work on a tongue position. I get the airways to make sure that the jaws grow properly. Sometimes I even do it in primary and mixed dentition, not all the time. I'm conscientious. I'll expand as early as possible if I need to. Like this kind of case is too late. The canine is already impacted. It should have been caught earlier. And now you're going to have all this complication. So why not do it early, and do the expansion? We know mandible obviously doesn't have sutures. So sometimes we, by extending the upper, you get autocorrection, but we'll also do some teeth expansion in an early stage. And we use different appliances if we need to, and if we don't need to, we don't use it. But some of those class 3 cases where the upper jaw is behind, we do first phase, and then we'll do second phase. We do a lot of like expansion appliances, make sure that we'll get this young, healthy patients, that the jaws and the teeth are going to actually grow properly. So we do a lot of phase 1 treatment, and I think it's very successful. This is one of the open bite cases that showed up at 16, and everybody wanted to do surgery. This was what like 20 years ago plus, when I first entered private practice. Family didn't have any money. So I treated her with a little expansion and the braces, 12 months, got her bite to close, converted her tongue habit, and really got a healthy, child that's now an adult. And, there's a lot of this orthodontic technologies that are accelerating tooth movement. I haven't seen clinical studies that really convince me to support that this is working. Some of you who have used it, that's fine. I mean, I haven't seen enough evidence to really adapt it quite a bit in my practice. And orthodontics is a great profession. We communicate the value of orthodontics to our patients. We talk about our patients, like, what are we about and what's our office about? And we keep telling them, here's the top things about our office. And those are 3 of my kids many years ago. Now they're all grown up. This is like probably 6 years early. And you can see the kids are growing up and technology is evolving. But thank you for listening. And I feel like I'm honored to being able to present to you. Again, I use Straumann aligners and Invisalign for my aligner cases. I use self-ligating braces to deliver low forces and expansion. I use the skeletal approaches. I do superimpositions. I use artificial intelligence to do diagnosis, and feel like it makes me a better orthodontist. And, I love practicing more than ever, and enjoy being an orthodontist. Very appreciative to the profession, and happy to give back. Anybody who is willing to reach out, who wants to become our orthodontic partner in our group, please reach out to me. Anybody who has questions about technology, of what I use and where you are in your pathway and journey, I would love to positively, influence each and every one of you, or people who are in the area would love to work together. And our practice is called Image Orthodontics. For those who want to write my cell number, it's 415-672-0917. Anyway, hope to see you sometime in a professional setting, and really thank you for the time and opportunity to listen to me, and looking forward to making our profession better. Thank you very much.